For years, menopause has been shrouded in misconceptions, cultural taboos, and medical misunderstandings, often dismissed as simply a natural part of aging that women must endure silently. Headlines occasionally proclaim revolutionary treatments or definitive solutions to menopausal symptoms, yet the reality remains far more complex than these simplified narratives suggest. Menopause is not a disease requiring a cure, nor is it merely an unfortunate inevitability to be suffered through without intervention. Rather, it represents a significant biological transition that profoundly affects nearly half the global population, influencing physical health, emotional well-being, cognitive function, cardiovascular risk, bone density, sexual health, and quality of life. What medical science has genuinely discovered over recent decades is not a single solution to eliminate menopause, but rather a sophisticated understanding of its mechanisms, a recognition of its wide-ranging impacts, and an expanding toolkit of evidence-based interventions that can help women navigate this transition with greater comfort, health, and empowerment. This knowledge becomes particularly crucial as populations age globally and women spend an increasingly substantial portion of their lives in the postmenopausal phase, making menopause not just an individual health concern, but a significant public health issue with implications for healthcare systems, workplaces, families, and societies worldwide. Menopause marks the permanent cessation of menstruation, officially diagnosed after 12 consecutive months without a menstrual period in the absence of other causes. This milestone typically occurs between the ages of 45 and 55, with the average age being around 51 years in most populations. However, the transition does not happen suddenly. The years leading up to menopause, known as perimenopause or the menopausal transition, can begin as early as the late 30s or early 40s, and typically last 4 to 8 years, though the duration varies considerably among individuals. During this transition period, ovarian function gradually declines, hormone production becomes irregular and unpredictable, and women may experience a constellation of symptoms even while still menstruating. The hormonal changes underlying menopause are profound and far-reaching. The ovaries, which have produced eggs and hormones since puberty, gradually diminish their function. Estrogen levels, which fluctuate throughout the menstrual cycle in reproductive years, become erratic during perimenopause before eventually declining to consistently low levels after menopause. Progesterone production similarly decreases. These hormones have influenced countless bodily functions throughout a woman's adult life, so their withdrawal affects multiple organ systems simultaneously. Estrogen receptors exist throughout the body, in the brain, bones, cardiovascular system, urogenital tissues, skin, and elsewhere, explaining why menopausal symptoms and consequences extend far beyond the reproductive system. The symptoms women experience during the menopausal transition vary dramatically in type, severity, duration, and impact on daily life. Some women navigate this period with minimal disruption, while others find their symptoms profoundly debilitating, affecting their work, relationships, sleep, and overall quality of life. Hot flashes, also called hot flushes, represent perhaps the most recognized menopausal symptom. These sudden sensations of intense heat, typically affecting the face, neck, and chest, often accompanied by sweating and followed by chills, can occur multiple times daily and may persist for years. The mechanisms triggering hot flashes involve the hypothalamus, the brain region regulating body temperature, which becomes more sensitive to slight temperature changes when estrogen levels decline. For many women, hot flashes represent more than mere discomfort. Severe or frequent episodes can disrupt work meetings, social interactions, and sleep, leading to fatigue and diminished quality of life. Night sweats, essentially hot flashes occurring during sleep, deserve special mention due to their impact on sleep quality. Women may wake multiple times nightly drenched in perspiration, requiring changes of nightclothes or bedding. This repeated sleep disruption leads to chronic sleep deprivation with cascading consequences, including daytime fatigue, difficulty concentrating, irritability, mood disturbances, and increased accident risk. The relationship between menopausal symptoms and sleep is bidirectional and complex, as declining estrogen also directly affects sleep architecture and quality independent of night sweats. Mood changes during the menopausal transition affect many women and can range from mild irritability to severe depression or anxiety. The fluctuating and ultimately declining hormone levels influence neurotransmitter systems in the brain that regulate mood, including serotonin, dopamine, and gamma-aminobutyric acid. Women with histories of depression, premenstrual syndrome, or postpartum mood disorders face elevated risk of experiencing significant mood symptoms during menopause. However, even women without such histories may find themselves uncharacteristically tearful, anxious, or irritable. The psychological impact of menopause extends beyond direct hormonal effects on brain chemistry. This transition occurs during a life stage often characterized by multiple stressors, including aging parents requiring care, children leaving home, career pressures, relationship changes, and confronting one's own aging and mortality. Cognitive changes represent another concern for many menopausal women. Complaints of memory difficulties, trouble concentrating, and mental fogginess are common during the transition. Research suggests these cognitive symptoms have biological basis related to estrogen's effects on brain function. Though distinguishing menopausal effects from normal age-related changes, sleep deprivation effects, and the impacts of stress proves challenging. For most women, cognitive symptoms improve after the transition is complete, though concerns about Alzheimer's disease risk have prompted important research into potential connections between menopause, hormone therapy, and long-term cognitive health. Urogenital symptoms, collectively termed genitourinary syndrome of menopause, significantly impact many women, but are often underreported due to embarrassment or misconceptions that nothing can help. Vaginal dryness, irritation, and atrophy result from declining estrogen levels in vaginal tissues, which become thinner, less elastic, and produce less natural lubrication. These changes can make sexual intercourse painful, a condition called dyspareunia, affecting intimate relationships and sexual satisfaction. Urinary symptoms including increased frequency, urgency, and recurrent urinary tract infections also become more common as urethral and bladder tissues are similarly affected by estrogen decline. Unlike hot flashes, which often improve with time, urogenital symptoms typically persist or worsen without treatment. Sexual function changes during menopause reflect multiple factors. Beyond the mechanical issues caused by vaginal changes, many women experience decreased libido or sex drive. This complex phenomenon relates partly to hormonal changes, particularly declining testosterone levels in addition to estrogen, but also connects to vaginal discomfort, body image concerns, relationship dynamics, and psychological factors. Conversely, some women report improved sexual satisfaction after menopause, freed from pregnancy concerns and sometimes from child-rearing responsibilities. Cardiovascular health deserves particular attention in the context of menopause. Before menopause, women enjoy relative protection from cardiovascular disease compared to men of similar ages, an advantage largely attributed to estrogen's favorable effects on cholesterol levels, blood vessel function, and other cardiovascular parameters. After menopause, cardiovascular disease risk rises substantially, and heart disease becomes the leading cause of death in postmenopausal women. This transition underscores the importance of cardiovascular risk factor management, including blood pressure control, cholesterol monitoring, diabetes prevention and management, smoking cessation, healthy diet, and regular physical activity during and after the menopausal transition. Bone health represents another critical concern. Estrogen plays essential roles in maintaining bone density, and its decline during menopause accelerates bone loss. In the first 5 to 7 years after menopause, women can lose up to 20% of their bone density, dramatically increasing osteoporosis and fracture risk. Hip, spine, and wrist fractures become increasingly common with age, and hip fractures in particular carry serious consequences including loss of independence, increased mortality risk, and reduced quality of life. Prevention strategies including adequate calcium and vitamin D intake, weight-bearing exercise, avoiding smoking and excessive alcohol, and when appropriate, medications to preserve bone density become increasingly important during and after menopause. Weight gain and changes in body composition commonly occur during the menopausal transition. Many women notice weight accumulating particularly around the abdomen rather than hips and thighs, a shift in fat distribution related to hormonal changes. This central adiposity carries greater health risks than peripheral fat distribution, increasing cardiovascular disease and diabetes risk. Metabolic rate also tends to decline with age and hormonal changes, meaning fewer calories are required to maintain weight. These changes frustrate many women who find that eating patterns that previously maintained stable weight now lead to gradual weight gain. Skin and hair changes reflect estrogen's effects on these tissues as well. Skin may become drier, thinner, and less elastic, with increased wrinkling. Hair may thin on the scalp, while conversely, unwanted facial hair may appear as the ratio of estrogen to androgens shifts. While these changes may seem cosmetic and therefore trivial compared to other health concerns, their impact on self-image and psychological well-being should not be dismissed. Managing menopausal symptoms and maintaining health during and after this transition involves multiple approaches, ranging from lifestyle modifications to medical interventions. The optimal strategy varies depending on symptom severity, personal health history, risk factors, values, and preferences. Hormone therapy, previously called hormone replacement therapy, remains the most effective treatment for vasomotor symptoms like hot flashes and night sweats. This treatment involves taking estrogen, usually combined with progesterone or a progestin for women who have not had a hysterectomy, to partially replace the hormones the ovaries no longer produce. Modern hormone therapy uses lower doses than earlier formulations and can be administered through various routes, including pills, patches, gels, and creams. The history of hormone therapy reflects evolving understanding and interpretation of research evidence. For decades, hormone therapy was prescribed widely, believed to protect against cardiovascular disease and other aging-related conditions, in addition to relieving symptoms. However, results from the Women's Health Initiative study published in 2002 revealed that for some women, particularly those starting hormone therapy many years after menopause, risks including increased breast cancer, stroke, and blood clots outweighed benefits. These findings dramatically changed prescribing patterns, with many women and physicians becoming wary of hormone therapy. Subsequent reanalysis and additional research have provided a more nuanced understanding. For healthy women beginning hormone therapy near the start of menopause for symptom management, benefits generally outweigh risks. The key factors include timing of initiation, duration of use, type of hormones used, route of administration, and individual risk factors. Current recommendations emphasize individualized decision-making, using the lowest effective dose for the shortest necessary duration, though what constitutes necessary duration remains debated. Some women need treatment for just a few years, while others experience symptom recurrence if they discontinue therapy and may choose longer-term use after careful discussion of ongoing risks and benefits. Hormone therapy effectively treats hot flashes, night sweats, vaginal symptoms, and may provide additional benefits for bone density and possibly quality of life. However, it is not appropriate for all women, particularly those with histories of breast cancer, blood clots, stroke, or certain other conditions. Non-hormonal medications offer alternatives for women who cannot or prefer not to use hormone therapy. Certain antidepressants, particularly selective serotonin reuptake inhibitors and serotonin norepinephrine reuptake inhibitors, reduce hot flash frequency and severity for many women even at doses lower than those used for depression. Other medications, including gabapentin, originally developed for seizures and nerve pain, and clonidine, a blood pressure medication, also help some women with vasomotor symptoms. For vaginal symptoms, local estrogen therapy applied directly to vaginal tissues provides effective relief with minimal systemic absorption, making it safer than systemic hormone therapy for most women, even some with contraindications to systemic treatment. Lifestyle modifications, while perhaps less dramatically effective than medications for severe symptoms, offer benefits without medication risks and support overall health. Regular physical activity helps with weight management, mood, sleep quality, bone health, and cardiovascular health. Weight-bearing and resistance exercises particularly benefit bone density. For hot flashes, some women find relief by identifying and avoiding triggers including spicy foods, hot beverages, alcohol, caffeine, and stressful situations. Dressing in layers, keeping environments cool, and using fans may provide comfort. Maintaining healthy sleep habits, including consistent sleep schedules, cool dark bedrooms, and avoiding screens before bed supports better sleep, despite night sweats. Dietary considerations for menopausal women emphasize adequate calcium and vitamin D for bone health, with recommendations typically suggesting 1,000 to 1,200 milligrams of calcium and 600 to 800 international units of vitamin D daily from diet and supplements combined. cardiovascular health benefits from diets rich in fruits, vegetables, whole grains, lean proteins, and healthy fats while limiting saturated fats, sodium, and added sugars. Some women explore phytoestrogens, plant compounds with weak estrogen-like effects found in soybeans and other foods, though research on their effectiveness for menopausal symptoms shows mixed results. Mind-body approaches including cognitive behavioral therapy, mindfulness meditation, and hypnosis show promise for managing hot flashes, improving sleep, and reducing distress related to menopausal symptoms. These interventions help women develop coping strategies, reframe their experience of symptoms, and reduce associated anxiety. The social and cultural dimensions of menopause deserve recognition. Women's experiences of and attitudes toward menopause vary across cultures, influenced by cultural beliefs about aging, femininity, and the meaning of menstruation cessation. In some cultures, menopause brings increased status and freedom, while in others it carries negative associations with aging and lost youth. Workplace considerations become increasingly important as more women remain in the workforce through their menopausal years. Hot flashes, sleep deprivation, mood changes, and cognitive symptoms can affect work performance and attendance. Yet menopause remains a topic many women hesitate to discuss with employers or colleagues due to stigma. Healthcare systems must adapt to better serve menopausal women. Many physicians receive limited training in menopause management, and women report difficulty finding knowledgeable, sympathetic providers. Comprehensive care requires time to discuss symptoms, treatment options, risks and benefits, and individual concerns. Yet healthcare systems often pressure clinicians toward brief appointments focused on acute issues rather than preventive care and quality of life. Looking forward, continued research is essential to better understand optimal approaches to managing menopausal symptoms and preventing long-term health consequences. Important questions remain about the risks and benefits of extended hormone therapy use, the potential for new medications with better benefit-risk profiles, strategies for preventing cognitive decline and dementia, and approaches to supporting healthy aging in postmenopausal women. Menopause represents not an ending, but a transition into a life phase that can span 3 or 4 decades. Supporting women through this transition with evidence-based information, effective treatments, empathy, and recognition of menopause as a legitimate health concern, rather than something to be endured silently, ultimately benefits not just individual women but families, workplaces, and societies. As populations age and women's roles in professional and public life continue expanding, addressing menopause effectively becomes increasingly important for public health, gender equity, and human well-being.